All right, so I hope everybody's had the chance to watch the first part of this. We broke it up into 2 nights because there was so much. So we're going to kick back off with pediatric emergencies for the second night. The class code will be at the end of this. If you've not had a chance to watch the first part, please go watch that so you're more prepared for your test, and we'll be getting on point on that. So starting off here, we'll talk about airway adjuncts. So remember, when we do adjuncts, we know how they're put in place. We know which ones we use for adults. So the question is which ones are going to be most efficient for the children? Sorry, I just hit a button on my computer and I don't, okay, there it is. Whew. So when it comes down to adjuncts, just knowing the oral adjunct, the nasal, the narrow nasopharyngeal is going to be a lot smaller, and you still measure them the same exact ways. They talk about bite blocks. The reason why we have and use bite blocks is if potentially somebody's having a seizure or the kid is seizing constantly, they won't bite your adjunct. So we go to do the bag valve mask. Now they do break those BVMs down into sizes, and most of them come in 3 sizes: adult and child and infant. A lot of times sometimes you just need to pick the right size for the right, even the right person. So I've actually used a child on a grown up. She was a little lady. I think she was like in her 40s, but she was tiny, and it's just the adult size just did not fit. So proper selection of the proper bag valve mask is what's going to be important to us. So the oral pharyngeal is the same thing as the adults. It's designed to keep the tongue from blocking the airway, and it makes suctioning out easier. Keeps everything open, so you don't have to worry about anything in there. So it's got lines down the side. You can run your tube down the side. If you'll look on your skill drill 35.2, it breaks it down and gives you some ideas for your book. It should be used for pediatric patients who are unconscious and the possible respiratory failure, because we need to secure that airway early. If we don't secure it early, we won't have, stand by, let me answer our other instructor. Blah, blah, blah. Secure that airway early, but that way that we're not worried about it when it comes down later. If we know that that child is compressed, if they're fading and going down super fast, we don't want to wait around and jump on that later. We want to be proactive instead of reactive. Doing the ability for, let me answer him real quick. Trying to get the class code to him so he can send to his full-time class. Yeah, so back to that. Being proactive in children is going to help you out in the longest period of time, because again, being proactive is the best thing to do for them. Jumping on it, being more aggressive. So if you try to use these on a gag reflex on somebody that's unconscious, you're going to constantly, even though they're unconscious, you're going to be like, and they may vomit, which is going to cause them to aspirate. So if you have a chance, don't worry about using the oral, go towards the nasal. And it may help you out in the long run, because now that you've got everything situated, you can get that airway under control and you'll be good. Talk about the nasal. So most of the time, pediatrics and adults can tolerate this a whole lot better. So it's used for responsive pediatric patients, used in association with possible respiratory failure, which rarely used in infants younger than 1 age, because it's so small. It's super small. Well, I don't know what's dinging around here. I don't know if y'all happen to hear that or if that's just me, but it's annoying. So hang on a second. Let me see what that is. I don't like that noise. I'm trying to concentrate over there and talk to you guys, and I'm just like, what's dinging in the background? All right, so most time your infants don't have to really much worry about that because everything's good. We talk about a potential problem. So we know that we're going to have problems when we start to secure. we're going to start having airways. If the airway is too long, it maybe stimulate the vagus nerve, which is a lot of slows the heart rate, or it's either going to enter the esophagus, causing gastric distension. So basically, that's like for paramedics, when we go to intubate them, we can either go into the stomach, or we're going to go, if we push too far, we're going to go right main stem. So the same thing, if you don't grab the right one, it may be a little bit longer, and you're going to have that issue to where it's either going to go into the stomach, or you're just going to go into to the right side of the main stem. Now again, that's rare, specifically on those those nasal pharyngeals, because you're not getting one that's that long. You still need to measure the proper placement and go into the proper placement of it. The nasal pharyngeal.
I didn't need to. Can I use that stand? That might work.
Did you say something, or you accidentally unmute?
Oh, sorry, that was an accident.
You're cool. Keep it cooking, bro. I hear it. Keep it cooking. So the nasopharyngeal airway should be used when the pediatric patients have facial trauma, because the airway may tear soft tissues. So remember, their bony structures have not formed completely. Everything's still spongy. Everything still has that elasticity. So using that during that phase is what potentially is what they're talking about. So you can potentially tear, because they're a hard plastic, versus the nasopharyngeal, which is like a pretty strong plastic, but they're very flexible. They move around a lot. I don't know why it's not clicking. So oxygen delivery systems, make sure you get the appropriate one for the appropriate age group. So it breaks it down there to the blow-by technique, the nasal cannula, non-rebreather mask, and the bad valve mask. So it's going from least to the most. So the blow-by, you're looking to potentially deliver up to 21%, but you're gonna put that about a 6 liters per minute on your regulator. So what that's doing is it's helping you potentially up them to 21%. It's laying here, and you're just getting the fresh air that's blowing in their face. So the nasal cannulas, the nose thongs that goes in your nose, be careful, unlatch those from the ambulance before you pull your patient out, because they'll be all pulled back like that. Just saying, I've done that on accident before. Make sure on the nasal cannulas, the highest you can go is 6. Now, you can turn it up to 15, and it looks like their nose is doing this, but it's not the right way. So 1 to 6 is on your nose, is on your nasal cannula. And then the non-rebreather mask, that is just the mask with the bag on it. That's 10 to 15 liters a minute. This is the same thing for your bag valve mask. If you're bagging them with supplemental oxygen, it needs to be set to 10 to 15. Majority of the time, you need to have that on 15 liters, because you're going to be supplementing them with bagging them, and that's coming. The O2 is coming out of the little reservoir bag. So we want to keep those two majority of the time at 15 liters. So use of a non-rebreather mask, a nasal cannula, and a simple face mask is indicated only for pediatric patients who have adequate respiratory tidal volumes. So if they're having normal, they're not having trouble breathing, you put it on there for just supplemental is the reason why we want to use that. Children with respiratory rates less than 12 and more than 60 breaths a minute have an altered mental status, and they do have an inadequate tidal volume at that point, and you should be assisting their respirations with a bag valve mask at that point. So the blow-by method is, again, y'all see it right there. It is not nearly effective as a nasal cannula or a simple face mask. It does not provide high concentration of oxygen, but it is better than no oxygen at all. So we are doing something, we are trying something, we are moving forward in that process, and that's why we have that there. It's something to get us by. They may not tolerate it, they may not like it, or allow you to have your mask on there, and that's fine. That's completely cool, but we're going to do something. So putting the blow-by is going to be there. It's better than nothing, just make them suffer at all. So the nasal cannula. So some pediatric patients prefer the nasal cannula over others, as you can see right here on this picture. That's your nasal, I call them nasal thongs. This just stuck for me forever. This is more of the blow-by method right here. You poke a hole in the end of the cup, you put the O2 tube in the cup. Now, and you can use a non-rebreather mask with the bag valve on there. That's okay. You can do both. This is something that they're used to. They have these devices that are also made into like bears, like plastic toys and stuff that you can hold in their face. Does the same thing if you're trying to deliver humidified oxygen or a breathing treatment. They kind of don't freak out as much when it's coming from a stuffed animal. So the non-rebreather mask does deliver up to 90% oxygen to the pediatric patient, but it still allows them to exhale their carbon dioxide without rebreathing it because it has the flapper valves on your non-rebreather. Once you hold it and you fill up that bag valve mask, you're good to go. You're ready to rock along. There you are. So the same thing, if once you breathe in, the one-way valves, they flutter, and that's it. That's all there is to it. On yours, it says applying the non-rebreather. So most services that I've been around only have two. You have your adult and your pediatric, and they're kept in different places. One of the services that I work for at home, they have a pediatric bag, and everything you need for a pediatric code, trauma code, anything for pediatrics, period, is in this bag. You don't have to look in the cabinet for your non-rebreather on the pediatric side. It's right there. You grab the orange bag, you know everything's in there. So that's very nice, and specifically like for other EMS services and fire services, you know if you have a pediatric call, you grab a different bag, and you ain't got to be searching for it, and you look like it shows you more professional because you know where everything's at. So the bag valve mask is indicated for pediatric patients who have a respiratory that's either too slow or it's too fast. Who are unresponsive? Let me start this. Who are unresponsive or do not respond in a purposeful way or to painful stimuli. So we need to supply supplemental oxygen. Well, how are we going to do it? Well, okay, we can bag them and assist them with their respirations. One person bag valve mask, the ventilations on a pediatric patient is okay. It should show you on the skill 35-4 on how to do that. But just remember when you go to bag anybody, I don't care how old they are, don't sit here and do this because you're going to hyperventilate them and that's not doing them any good because it can either overfill and then you're going to basically, you're not overfilling their lungs, but it's going to not let them exhale properly, or you're going to turn around and put into gastric distension. And that's not a good thing too, because it's got to go two ways, up or down. I'm going to let you make that choice, but it's not good to hyperventilate either. There's your slide on the pediatric non-rebreather and the pediatric bag valve mask. That is a child specific. You see it has its, both of these have their reservoir bag here, and they are filled and ventilated. This one automatically fills when it hooked up. This one right here, you have to put your finger on that one-way, little one-way valve right there. And once that bag is full, then you can place it on the patient. So this one automatically fills, and when you bag them, it takes oxygen from that reservoir bag and puts it down through the tube. And there's a one-way valve in here too, so if they happen to vomit, it's not going to get into the rest of the bag. So the two-person bag valve mask on a pediatric patient is anything with assistance is going to be better than you having to unfortunately do it by yourself. So that being the case is when you're doing it with another person, somebody is going to hold just the mask. Somebody's responsible for the good EC placement because you're going to hold it down with their jaw. You're going to clamp it. These fingers are going to hold the jaw, and you're going to hold the mask down just like this. So the mask goes here, and your fingers go across the bottom parts of their jaw, and you're able to hold it tight. You have to do a head tilt chin lift. You can do the same thing, and it functions a lot better. And then one person specifically just bags. You got to have the people too. And cardiac arrest, most often associated with respiratory failure.
Can't hear you, Chris, if you're talking. All right, is that better? Y'all hear me now?
Yeah, I can hear you now.
I guess my headphones died. Sorry about that, y'all. So on cardiac arrest, most time for infants, your pediatric patients do go into respiratory failure because, cardiac arrest because of respiratory failure. And that's 99% of the problem. So if you can fix their breathing and supply supplemental oxygen, it's not meaning that they're automatically going to be like, okay, hey, I'm better. What's up? What's going on? But you should know what majority of the problem is going to be from, because that is something that it's about an 80% cause of cardiac arrest because of the respiratory failure. Folks, your focus should be on CPR, but use of early defibrillation in kids have a big turnaround and the results of things. So the faster that you can get the AED there and deliver a shot and then transport, you're going to have a better outcome of that pediatric patient. Circulation emergencies and management, look for shock, signs of shock. What am I doing? Do I have a baseline vitals? Well, it depends on how old they are. If you're going to get a good set of vitals or not. Results in if you don't, some signs of shock are going to cause organ failures. You may have compensated shock in the early signs of stage of shock when the body can still compensate for the blood loss. So the body's going to shunt. If there's a big enough injury where they're leaking blood everywhere, the body's going to start shunting from the extremities to the core because it's trying its best to keep the core from the abdominal area to the heart to the brain. That's your core part of your body that they're trying their best to keep alive. So with that in case, if you reach up and you don't feel a pedal pulse, that's showing you that they're probably in late stages of shock because the body's shutting down. Now, again, that's a massive injury, so we're going to try to stop that first. We know that the bleeding is taking place, so we're going to take care of the bleeding, stop that problem, and we're going to move forward. So hopefully that we can allow their body to start compensating, and now with our treatment that they should start to get better. Just depends on how much blood is out there. So decompensated shock is the later stage of shock. It's when the blood pressure just cannot work. The heart is pumping, but at some point when the body has lost so much blood, it's like a motor trying to pump air. It's not going to work. It's used to pumping a fluid. It's the same thing with the heart. It's used to pumping a fluid and it's blood. And if there's not enough blood in there, that heart's going to try to pump air and it's just not going to work right. So in pediatric patients, the most common cause of shock are right there: trauma, injury with blood loss, dehydration from diarrhea or vomiting, severe infection, and a neurologic injury. Okay, so we can potentially fix number one. We as basics can't fix number two because we don't have the means of starting an IV. That's the reason why we try to hint to parents in learning education is Pedialyte, water. Try to get them to drink something, even though they're sick, that can help them from being dehydrated. We can't fix the severe infection. That's a medical facility. But if we recognize the shock, we can get them to the facility that's most appropriate to them. Now, neurologic injuries, we can't help with TBIs. We can't help with the coup contre coup injuries, or to even further than that. But we know what to do. We know to stabilize them, supply supplemental oxygen, move forward. So doing that, we're doing a lot more than us not, you're learning enough right now to take care of them to move forward to where you can help that patient push forward in life. So a severe allergic reaction, anaphylaxis, disease of the heart, tension pneumo, and blood around the heart. So blood goes in and through. Being around and in that pleural space is not good for the blood. It puts a severe load on it and it's a lot of pressure. So tension pneumo, as basics, we can't fix that. Now, if it's recognized and it's confirmed by a paramedic, they can put a decompression needle on there. There's two places you can put it, and hopefully they can do it and help relieve that. So heart disease, again, we can't do anything about that, but ask questions, ask early. They may tell you, hey, noticed a lot of fluid buildup. The doctors try to, start putting them on dialysis. But for why? Ask these questions that help build that case to where when you get to the facility, you can try to pass this information on. Now, a lot of times the doctors aren't going to listen to you until they get used to you. So if you build a good rapport with them and you start working with it, they may pick you up from the beginning. Pediatrics will always respond differently than adults do on anything. So again, back to my analogy of a 16-ounce soda versus a 2-liter Coke bottle. So a child and an adult. You lose so much blood loss, they're gonna have more problems than the adult because we carry more. Can anybody tell me how many liters of blood we carry as an adult versus the pediatrics? Google that real quick. So you're looking at their heart rate's going to fail faster. The increased respirations, you're going to start seeing the seesaw effect. You're going to see them looking in the tripod and show signs of pale or blue skin. They're going to decompensate so much faster that you're going to see these signs of shock, and they decompensate fast. So when you see it, it's already too late. Signs of adult is like 5 liters. That is correct. Signs of shock in children follow: tachycardia, poor cap refill, mental status change. Beginning treatment shock is assessed by the ABCs. Interventions are required. If there is obvious signs of life-threatening external hemorrhage, the order becomes CAB because of the bleeding control is the most critical step. If cardiac arrest is suspected, the order becomes also CAB because the chest compressions are very essential. Pediatric patients in shock often have increased respirations but do not demonstrate the fall of blood pressure until the shock is severe because they're holding their own. And then when it gets there, it is a 90-degree fall. It is not a slow decrease. They go from like 95 down. So 0.5 in gallons, so 0.7 in gallons. So if you think about doing the differences, that's a lot. Look at that, 5 liters. And if y'all can transfer from 0.7 gallons over to liters, you'll notice there's a big difference of change there. Treatment of shock. So what are we going to do? We're going to ensure that their airway is open, that the airway is maintained either by them or by me. We're going to prepare for artificial ventilations. We're going to put them on supplemental oxygen. Control any bleeding that we see that is just very obvious. Or if you're looking at it like, man, there's some blood from somewhere, let's find it, let's stop it. Giving supplemental oxygen by mask, blow by, I don't care how you do it, get them some oxygen. Do your best to keep these babies warm. It don't matter if you're sweating your butt off in the back of that ambulance and you're hustling, moving, and you're just like, oh my God, it's hot. If that baby is cold, it's your fault. You need to warm them. Provide rapid transport to the nearest facility and the nearest appropriate, let me say it that way. And contact ALS for backup as needed. Pretty much you're going to want some help. When you get there and you're like, oh God, this is bad. I need some help. Remember, your help has to get out there from where y'all started from. So early notification is your best friend. Limit your management of these simple interventions. Ensure the airway is open. Prepare for artificial ventilations. Control bleeding. Why isn't it already? Whoops. Let me back up here. Let's talk about anaphylaxis, and I think I went a little fast. So anaphylaxis is also called anaphylactic shock. It is a life-threatening allergic reaction. It normally is generalized, can be multi-system, and it's reacting to an antigen, a bee sting, peanuts, I don't know, all these other allergies that we have out there. They are characterized by airway swelling and dilation of blood vessels. So you may notice that they have trouble talking or swallowing because their airway's closing up. Common causes are insects, medications, foods. I've seen them down to the allergies where one of the old hands had some latex gloves. The kid was allergic to latex, and you could see when they grabbed them to help move them over, the handprint from the latex covered, and they end up having a allergic reaction later down the road. Signs and symptoms, you have hyperperfusion. So knowing your baseline vitals is, again, very important. You start to notice the respiratory problems, the I can't breathe, and you hear the hee, hee when they start breathing. So their increased work of breathing, now it is a struggle for them to breathe. What are you going to do? Well, we have this pretty cool stuff. It's odorless and tasteless gas on your ambulance. That's called oxygen. That's going to help them. So altered appearance with the restlessness, agitation, and sometimes sense of impending doom, they're going to look at you and say, I feel like I'm dying. Well, I don't want you to die on my ambulance today, and we don't allow people to die on Tuesdays out here. So we're going to do everything we can to make you feel somewhat better. Don't ever tell them, oh, you're going to be fine. Quit saying that. I'm going to take care of you. You don't die with me back here. Bet they will. I bet they will. So what I'm going to do here, going to, again, manage their airway. Going to provide supplemental O2. Do your best. It ain't going to work, but do your best to keep the patient very calm. You assist with the ventilations. If they have a, let's see, if they have an EpiPen, assist that with the parent. If not, you can call sometimes for orders. Sometimes I've seen basic trucks carry EpiPens on the ambulance with them. It just depends. The cost issue is the problem. And then you provide rapid transport and meeting an ALS unit en route. Some neurological emergencies and management. What am I going to do for these babies that have altered mental status? Well, your first thing you're looking for is the abnormal neurologic state in which a pediatric patient is less alert and interactive than what we should be at that age. Now, if they're just like, they have no verbal tone or anything like that, get concerned. They look at you in the eyes, but they look straight through you. Understanding normal development or age-related changes of behavior and listening carefully to the caregiver's opinions are very key. They know those babies. They know what's going on. So we talk about the mnemonic AEIOU tips, and that reflects the major cause of altered mental status. And as you can see on your screen, AEIOU tips is right here. Have they potentially gotten into some alcohol, somebody's insulin, some opioids or other types of drugs that has affected their mental status? I see a lot of these videos here lately on TikTok. It's not funny, but again, it is comical of the animals getting into people's weed and stuff like that, and the dogs being super hot, unable to stand up. It's the same thing for children. They'll eat it too. They just don't know no better. And once they ingest it, it may take a hot minute, but when they fully get the effect of that bud, it's over, bro. They're gonna have all of those same symptoms: unable to stand up, pinpoint pupils, dry mouth. So look for the AEIOU tips. AEIOU tips. It's another mnemonic to help you build your database of information on your patient. You're doing that investigation, and now we're giving you more and more tools to get information. Be like, what's really wrong with them? Well, now I can start asking, any alcohol in the last 12 hours? Have they had access to it, or have you found any empty bottles? Epilepsy, endocrine, and electrolytes. Have they? Just start asking questions. I don't use AEIOU tips because I don't know it that well, but I ask the same questions in my own way. But if you're going to learn it, let's use the tools that you have. Some signs and symptoms vary from simple confusion to a coma. You're going to manage those ABCs. Now, seizures are very scary because we know that they can have multifocal seizures. They can have seizures. They can have tonic-clonic, grand mal. They can have numerous types of seizures, and they respond differently. And it's always scary to see a child seize because you can't do anything about it. You have to figure out, oh God, I hope mama's got some medications on her because we ain't got none. Until the truck gets here, we're gonna look like crap. But there's other things you can do. Move the things around them. The children's going to have that sucking, or they're going to start sounding like they're biting, and that's their molars. They're grinding their molars back and forth. Be very cautious of that. It's very, don't ever put your finger in there. The bicycling motion is them rubbing their feet like they're trying to run. That's their motion for seizing. And older children's seizures are more obvious and typical, consistent of relative muscle contractions and unresponsiveness. So sometimes in kids just may not act right. And that may be what you called for, because the parents like, my babies, they just not acting right. And ask those questions, and knowing a better understanding of how smaller children seize, and it doesn't just have to be a full body seize for them to start seizing. It can be, the bicycling motion, the abnormal gaze, and the sucking motion. Those are small symptoms of a seizure, and those. Take a look at the cause of seizures right there. I'm gonna give me a drink of water. Sometimes you just don't know what has caused their seizure. There's none of them that's lifted, and the last one on the page, and you're like, well, I don't know. Let's just take them to the hospital. And again, that's okay. We just don't know. There's tons of things you can look at that on that page right there, and you see medications. They could have got into grandma's meds that doesn't have the child safety lock on there because she can't open it. So she flips it over and has her medicine stored like that. Now the grandkids gotten into it. So once the seizure stops, the patient's muscles relax and they become more facet or floppy, and the breathing becomes labored, and that's called the postictal state. Now, that being the case is, they're going to be very, very confused. I don't know if anybody has any reference with people with seizures, or if y'all happen to have seizures, but on pediatric patients, once they get their wits and they start coming around, they're just going to be like you and I. There's going to have their normalness. It's going to be the postictal state's over, and that's where the confusion starts for the parents. And the first time having a seizure, and my baby's this and my baby that. I've been there. I get it. But remember, the EMS we don't know it all, but we want to know. So ask those questions. Have they had this in the past? Are they on any current medication that potentially has listed side effects of seizures? Build that information and take a list of that medicine. If you happen to build information saying that, hey, hang on, let me text. Once they kind of stop seizing, they should come back to normalcy. Now their normalcy maybe whatever is normal for them, and ask those questions. Hey, what is normal for my child? Hang on one second, y'all. right, guys. Sorry, that's when the big boss calls. You got to jump on that one. All right. So seizures that continue every few minutes without gaining any type of consciousness, and they last about 30 minutes or longer, that is referred to as the status epilepticus. Blah, 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 blah. So reoccurring and prolonged seizures should be considered life-threatening if they seize back to back to back to back. Those, and there's no period of break. That needs to be transported immediately, and that needs to be seen by a neurologist and needs to be taken care of. If the patient does not regain consciousness or continues to seize, you need to protect the patient from harming him or herself and call for immediate backup. Some sedation, some medication needs to be put on board to help those babies out. And it's the same thing for adults. It doesn't just have to be with kids, but that's something that we need to jump on because we know what we need to do to treat them. So let's just make that happen. Remember, knowing what to do and not acting on it is going to cause you for negligence, and none of us want that. So on management, what we want to do is secure that airway early if we have to. So when I say secure, hang on. So we talk about securing and protecting the patient's airway is our priority. Now, if they're seizing and their O2 sats don't drop, or you're able to just hold the O2 mask on there and their O2 sats don't drop, that's fine. It's going to be impossible for you to try to put a OPA or an MPA in while they're seizing. It's going to cause harm. Their teeth may be locked down. They're not going to be able to do that. So just holding that mask on there probably going to be more beneficial than anything. Place the child in the recovery position if vomiting or suction is inadequate. So remember the recovery position. Let's go back to your basics of CPR. Left side, put them on their left side, the arm out, the right side tucked underneath. So it helps them stay in a position to where they can still breathe and their organs aren't pushing on anything. And providing 100% of oxygen. Just put them on oxygen. Remember, that's since day one. We're going to continue to put them on oxygen. Some caregivers will have the child a rectal dose of diazepam or prior to your arrival. Monitor breathing and level of consciousness very carefully and transport it. So if the parent delivers the diazepam or Valium or anything like that, please note the time that was given and relay that on to the hospital. Parent provided rectal dose of diazepam at 1700. And the reason why is because there's a time that we can provide more medications, but when they get to the hospital, they don't know if it's not told to them, they don't know what the first dose was and when it was. If you can take the vial of medication that parent used, I don't want you to take the syringe, it's not really important to us, but take the vial so they know the exact milligrams and the dosage. We know the route. So talking about meningitis. So meningitis is a tissue issue and it covers the spinal cord and the brain. And that's all inflammation. So when we have, it's an infection, but it's a constant inflammation of those tissues. So when they say, I want you to recognize that and understand that trying to figure out meningitis it's requiring you to ask a lot of questions. Any recent travel outside of the country, all these other things that you need to do to understand if it's meningitis. Well, I don't know if it's meningitis. I recognizing it's cool, but what am I going to do with it? So some of the ones that are higher risk than others, let me look on yours. Males, newborn infants, compromised immune systems by age or cancer, history of brain, spinal cord, and back surgeries, children who have had head trauma, children with shunts, pins, or other foreign bodies in their brain or spinal cord. I don't know why it affects them the most, but it does. All of us men and babies, we had something to look forward to as being born. Obviously, we beat that record, so we're good. Some signs and symptoms: a fever of altered level of consciousness, and common symptoms of all ages. We know that little ones are going to have fever out of the blue, but they're not going to have that mental change of altered level of consciousness. They're still going to whine, they're going to cry, they're going to just look like crap. But if they're just very lethargic and you're as a stranger able to walk over there and pick them up, that's not normal. Children may also experience seizures, which will be the first sign of meningitis. Infants younger than 2 to 3 months can have apnea, cyanosis, fever, and distant high-pitched cry or hypothermia. So the body temp's going to drop. We know that. So that high cry, I don't know why it does that. I have no idea, but it affects the respiratory system and it puts them in that drive to. It has like that whistle when they breathe. I've seen it twice. Not one was in my patient, but it didn't have meningitis, but there was a high pitch, and that's the first thing that they thought of. So you can have meningeal irritation. I've never heard of a patient with meningitis. Yeah, it's not as common as it used to be. There's a lot more that's more common in pediatrics than they teach us about. But remember, we're only teaching you a percentage of what is out there for you to learn, because you can be tested off the national DOT standard of EMS. You can be tested off of any part of that book, but we can only teach a percentage. Now, I mean, if we could go page by page, but it would be a lot longer than what we do. And I don't know if any one of y'all are going to listen to me every single night doing that way. And I'm not monotone, and I don't know if I would want to do it. So let's get back here. So often results in a stiff neck. That is your most common sign. If the pediatric's like, it just really hurts and they're just real stiff, ask them, hey, did you sleep wrong? Did you have any issues? No, it's just I constantly have neck pain. And you start asking, what's it like? It's stiff. I can't turn. Or if the parents, complain that they just been like that for a couple of days. One sign of meningitis in an infant is increasing irritability and the bulging of fontanelle with no crying. That's the thing. That's going to get you. When this starts bulging, that's not dehydration, because we know we're going to be a scoop. Oh, you can't see my hair. I'm going to rest my hair. You can't see the indention, but you can see that bulge. If it's a deep indention and you do see it, that baby is severely sick. But if you have that bulge, you're like, that don't look right. That should get your attention too. Neisseria meningitis is a bacteria that's caused a rapid onset of meningitis symptoms, and it often leads to shock or death. That's unfortunate. Children with meningitis typically have small, pinpoint cherry red spots or larger purple, black rashes on their face and body. Here's a picture right here. That is a Neisseria meningitis. They have the small pinpoint cherry red spots on them. You can see some of the bigger ones that are black. This is what they refer to, black or purple, right in here. And the rest of these, I don't know about y'all, but I'm just gonna say that is not a child, because they already got the flat feet. They got the heels need to be gone. They need to go to the little foot shop, but I think that's more of an elderly patient, and I would lean more towards shingles on that one. I'm not a professional, but specifically it's an elderly patient there. All pediatric patients with suspected meningitis should be considered contagious. So you're going to have to be looked at too. They're going to have to tell you. You need to follow standard procedures about that. You may have to gown, goggles, guys, mask, double glove, tie your gown up. If you're exposed to any saliva or respiratory secretions, so you get any kind of spit on you, you should receive antibiotics also. Treatment of children with meningitis, provide supplemental oxygen with ventilations, reassess vital signs frequently during transport and to the highest level of bail. You need to let the receiving facility know that you potentially suspect meningitis and why. I visually see these red cherry bright red cherry spots on them. The child's very lethargic, blah, 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 and then relay that information to the facility. Because if you don't, and you just show up with that, they're going to hate you. God, they're going to hate you. Now, be cautious when you put the mask on them because of the O2 mask, because remember, that's high flow O2. So the air's coming in and it's gonna go out, but there's no filter on that. So if they do sneeze, it's gonna aerolize, so be cautious. Poison emergencies. If you call poison control, be prepared, they'll call you back. I don't like calling them from my cell phone for that particular reason. If I do call them, I will call them from the parent's phone, and we will talk to them about like that. So the parents can talk to them about every 3 hours later. There's a table listed in your book, 3513, it's common sources of poisonings, but anything at all can cause a poisoning. Mistletoe is very dangerous to animals and to children if they eat those little red balls. It can kill them. It's a beautiful plant, but it's very, very poisonous. Overdose on iron, prescription meds, illicit drugs. Who knows? Imagine that. Some substances only take one pill to be lethal in a small kid. It's just very dangerous these days. I mean, you got to think about the stuff that is out there, the accessibility to them. So you got to think, obviously I'm the oldest one, but what I have now, and I have the world at my fingertips, my child has at 17. I didn't have that into my 20s. So I knew better, but he doesn't know better at 17. My daughter gets on my phone and plays, watches the little YouTube crap that keeps showing up about horses all over my phone. She's 9 and she has the access to the world at her fingers. So imagine what they have gaining access to when it comes to illicit drugs and street drugs and all these other things. It's there. I love to hear people say drugs aren't in my community. It's because you don't look for them. One of the biggest drug busts I've ever heard of was in one of my old towns and down the street from the old house I used to live in. So they there, you just not looking for them. Infants may be poisoned as a result of being fed harmful substances by a sibling. Kid just doesn't know, maybe by a caregiver. Be alert for signs of abuse. They may be exposed in a setting in which harmful substances are being smoked. You think of that one. You have completed your primary assessment. Ask the patient or caregiver the following questions. What is the substance involved? Approximately how much of the substance was ingested or involved in this exposure? And then what time does it happen? Because we're going to have to give them some medicine at some point, either with us or at the facility. They just need to know what time. Are there any changes of behavioral or level of consciousness prior to my arrival? And was there any choking or coughing after the exposure? And what you're doing there is you're checking their airway. They have any respiratory problems is why you want to know. Contact poison control, be careful. In some cases, you may have to give activated charcoal, according to medical director or local protocol, depending on what your agency requires you to do. So remember, that's going to be one of those that follow your protocol and know. If you're not sure, just call Med Control. They get paid way more than we do to make those decisions and help you out. So dehydration is another huge issue. And sometimes kids just literally will get dehydrated just like that. Vomiting and diarrhea are some common causes of dehydration. If you don't treat it, the parents don't do anything, dehydration can be, it's going to potentially cause death. That's the reason why you don't want your kid to vomit, let's say more than 6 to 7 times, because what's going out is not going back in. So you're losing. Now, granted, if something's on their stomach, that needs to go. We get that. So infants and children are greater risk than adults for dehydration because their fluid reserve is just not as good as ours. Again, the size model there, small kid, big kid, it's just not the same. Life-threatening dehydration can overcome the infant in a matter of hours, and dehydration can be mild, severe, or moderate. They classify them different. There's some signs of mild dehydration, moderate dehydration, and severe dehydration. I want to show you this picture. Look how dehydrated that baby is. What, I don't know what else you can say besides that's child abuse. That's 100% child abuse right there. And we're the first ones to recognize that. Now, granted, I'm sure this, I mean, you can look, the denim shirt and the belt buckle and all the belt right there. That's probably a super old picture. But they called you to come pick that baby up. What you gonna do? Well, most likely the altered mental status of that child is going to be different. And they're just gonna come to you or be very lethargic when you go to pick them up. Well, the first thing you want to do is, as a caregiver in EMS, you want to grab that baby. And they're just like, what's up? They just don't care. They're out of it. Fever and emergencies. So remember, nowadays they say anything 99 technically is not a fever, but they start classifying things as 100 to 100.4. You don't, and once it starts getting into like 103, 104, that's going to affect the brain. That needs to be addressed ASAP. You need to try to cool the child, move. Sorry, I'm kind of getting off. It may address that in a little bit. So what's going to potentially cause our seizure, our fever infections because of white blood cells counts going up. Maybe status epilepticus, and you're going to start seeing a seizure the higher that temperature goes. You may have cancer that's starting to affect this child. Drug ingestion, aspirin will do that to them. The babies ingest a lot of high dose of amount of aspirin, gonna get some high fever. Arthritis and systematic lupus, it's rashes across the nose, higher environmental temperatures. Fever is the result of an internal body mechanism in which the heat generation is increased and heat loss is decreased. Accurate body temperature is an important vital sign for pediatric patients. A rectal temperature is the most accurate for infants and toddlers. That's the reason why when you go to pediatric side of the ER, they don't say, open your mouth, baby. Bend over. You're like, I'm sorry, what you gonna do to my kid? And it's just because that's the most accurate, because they're not gonna learn, they don't know how to put their tongue down on it yet. Keep it underneath your tongue. It's gonna be like, you're gonna see them sitting there playing with it, and that stick's gonna be moving in their mouth. So be cautious. Even though we have all these temporal detectors now, they suck. They don't work. We know they were just punting them out as fast as they could because fever was a sign of COVID. It's a late sign. Like the other day when I had a sinus infection, the lady said, do you have any fever? No, ma'am. Do you have a runny nose? Are you coughing up snot? Yes, ma'am. Well, that's a sign of COVID. Ma'am, I've had COVID twice. I've never, ever had that. So everything is signs of COVID now. So there's no flu around. I don't know if you'll picked up that on your own. No, let's see. Depending on the source of the infection, the pediatric patient may present with signs of respiratory distress, shock, stiff neck, remember meningitis, a rash on the skin that is, and the skin is too hot to touch, they're flushed, they're seizures, infants and bulging fontanelles. Now remember, when we say flushed, it's going to be majority of their cheeks are going to be flushed, their extremities, especially like their arms. Some kid, and I've got two kids that are completely separate. They're different. One carries their fever on their head. The other one carries it on her chest. My daughter can run 101 fever, touch her forehead, ain't nothing there. You got to feel her chest, and she's burning up. The other one, his chest is ice cold, and his head's on fire. So, no, check both places. Put the back of your hand on their chest, see if they can feel it, and tell these babies, hey, this is what I'm fixing to do. I want to feel your chest to see how warm your chest is, and let mom and dad know, hey, this is why I'm doing it, just in case. Again, follow the protocols for your area. They may require you to not do a temperature. They may get a temporal reading. For what? It's not going to work the best. So febrile seizures are very common in kids. They do last shorter than 15 minutes. They may or may not have a postictal state. Most pediatric seizures are a result of fever, which is why they're called febrile. They typically occur the first day of febrile illnesses. They're characterized by the generalized tonic-clonic seizure activity, and they may be signs of more serious problems such as meningitis, or now that it's opened the doors to move into something bigger. You should see this potential issue in the febrile seizures from the 6 months to the 6 years age. And then they kind of grow out of it. They may, if they have seizures past that date, they may not be considered febrile seizures. They have another classification. The tonic-clonic, the grand mal, the stuff like that. You can still get sick as a dog and have fever problems. So it's not like it's just something besides fever causing. It's just you have such a high fever that the fever is causing your seizures the older you get. Always assess your ABCs. On febrile seizure patients, they need to be in a hospital setting as soon as you can, but there's things that we can still do to treat them, which we know make them comfortable, keep them comfortable, try to ease their, don't let them stress out, try to keep them just as calm as you are, hopefully, but know that you have the ability to do some things for them. The O2, position of comfort, calming mechanisms, and just talking to them may just help. Please remember, if these children or adults or anybody has a service animal, especially a medical service animal, they need to go with them. Well, any service animal we have to allow. That's why I want my monkey. But they'll give you an idea too. Ask mom, be like, what kind of service animal do they have? And they may say, well, they detect high blood sugar. And you're like, oh, I really want to see this. Like, I really want to see one of those dogs. They start nudging them, and then they touch the top of their hand or the bottom of their hand that tells them if it's high or low. Like, I want to see this. Like, I think that's pretty cool. Like, I want a service monkey. Like, let me know. Before we dig off into this, because this one's, we start getting a little deeper. We don't have that many slides. We've got to go. Let me figure out what slide I slid past it now. We're on 172. We got to go to 227, so we don't have that many left. Let's take a 10-minute break and see you back at 8 after 7, and we'll get going from there. All right, sorry, we're back. Let's get this going. All right, so on drowning, the secondary most common cause of unintentional deaths among children 1 to 4 in the U.S. So that's a lot. I mean, you gotta think it's a lot of deaths just by drowning, y'all. Children often fall into swimming pools, lakes, and but may drown in bathtubs and even puddles, buckets of water. So this doesn't have to be deep. It can be of any type of water that can cover their face. Some older adolescent children drown when swimming or boating. Alcohol is frequently a factor. Principal conditions that result in drowning, it's a lack of oxygen, we know that. Even a few minutes without oxygen to the heart and lungs can cause death of injuries, can have brain injuries, can have long-lasting problems. Submersion in icy waters can lead to hypothermia. Remember, nobody is deceased until they're warm and dry. Thank you, Caesar. You got to be warm and dry to be pronounced deceased. There is a record. I'm not going to say like it's a, oh, look at me record, but the longest time that somebody was submerged and turned around and was brought back to life due to CPR, long-term proper ventilation, good chest compressions was 4 hours. But that's a cold water drowning. So it's not something that's going to take place in the South. Even when it's cold, our water is technically considered warm water. And then think about diving into water increases the risk of nested spinal cord. That's why you go to all these hotels and stuff, and they have all these signs put out. It's like no diving. It's just an insurance policy. It's to make sure if something happens, that's on you. We didn't do that. Now, I'm sure like everything else, there'll be lawsuits and all that other stuff, but not like as much as if there was no sign around. Didn't want to click. Some signs and symptoms are based on the type of length of submersion. A pediatric patient may present with coughing, choking, airway obstruction, difficulty breathing, altered mental status, seizure activity, unresponsiveness, fast and slow, or no pulse, pale cyanotic skin, and abdominal distension. And the abdominal distension is because of think of the gasp of water and it went down. Some of your management. The first thing you need to do is when you recognize a drowning, even if it's a shallow water, cold water, partial drowning, you need to get ALS there fast because they need to secure that airway and you don't have much time to do that. Request and manage their ABCs, access and manage, sorry. Administer oxygen, not high flow, through a bag valve mask. Have suction ready because that water is going to come up even if you start CPR and then you start doing ventilations, even if they do come around, copious amounts of water is coming up. If you suspect trauma at all, apply a C-collar, manage that spinal cord, be protective in the head. Know that if you have them on a backboard and they start vomiting, you need to flip them to their left side as fast as you can. And having multiple responders on scene is going to be beneficiary to you because even if you transport from the scene onto meet ALS, you got a lot of stuff to do. So the more people that you have, the better off you are. That's why I've never turned down help. And when I transport somebody, if they're like, hey, do you need a rider? Yes, I do. I don't care if it's granny that slipped, tripped, and fell and bumped her head. Yes, I do. Why wouldn't I want free labor? Why wouldn't I want a free hand back there? Even if they don't wholeheartedly understand and know what they're doing, guess what? I can tell them what to do. My monkey was back there with me because I'm emotionally distraught. I can tell my monkey to do something. So it's cool to have extra help. Always keep an extra hand if they offer it. I'm telling you, on any type of first aid call or trauma like that, don't turn down the help. Pediatric traumas, some unintentional injuries are the #1 killer of children in the U.S. Quality of care in the first few minutes after the child has been injured can be enormous. It's enormous impact on their potential recovery. So having the proper care and the proper amount and a quick response is going to be beneficial to that child. The muscles and bones of children continue to grow well into adolescence. We know Adolescents are prone to fractures of the extremities because they're still growing, and we slip, trip, and fall. We're going to land on it. We're going to brace ourselves and stuff like that. A fracture at the femur is pretty rare in pediatric patients, but when it does, it's going to produce a major amount of blood loss. Older children and adolescents are prone to long bone fractures, which is going to be your femur and your humerus, because they tend to take more risk and during physical activities. Watch me. It's the guy syndrome. It's the easiest way I can tell you. Some of the physical differences is children's bones are soft, as they're well developed in those of an adult, and therefore the force of the injury affects these structures differently. So that's where you get the green break in the child's arm versus we're going to have a major break of the radius and ulna. So you may see the child's arm, this part may just be curvy, and then in an adult, it may be an open fracture. So those are some of the common differences there. Because a child's head's proportionally larger than adults, it exerts greater stress to the neck during deceleration injury because it's heavier, it's going to lean. If they slip, trip, and fall, or if they fall off of something, they're most likely going to go head first because they got some big old heads. Let me just be honest. They be like, boy, I feel sorry for your mama, because that's the biggest part of their body right now. Children often are injured because of their undeveloped judgment and their lack of experience. They rookies. They don't know. They hadn't had the chance to learn. They hadn't had that call. Put me in, coach. They see others do it and assume that it's okay for them to do it. Anytime that you go to an incident with a child and they're complaining, neck pain, always assume that they have a head injury or a neck injury. It's easier to put them in a collar and transport them than transport them with none of that, and they move and it causes more damage because that's neglect. If they can't tolerate it, it's okay when you put it on there. May not latch it super, super tight because you don't want to just hold their necks like this. But if they say, hey, look, we're going to deal with you. Let's put this on, and I won't latch it super tight. I just don't want you to move because I don't want your neck to move up and down. And they may bite the bullet and take it with you. Head injuries are common in children because of the size of the head. We talked about that. Scalp, facial injuries, they're going to bleed a lot. They're very venous areas. You're going to be like, oh my God, what is they bleeding from? You got to figure out, once you clean it off and you see like the nick right there, you're like, bruh, what you doing? So those are some of the things that will freak out other parents and stuff, and specifically their parents. An infant does have a softer, thinner skull. So just remember, if there's any head injuries, make sure when you palpate, don't push. You want to kind of feel with a flat hand. You don't want to feel with your fingers like we do on our adolescents to adults, because if we accidentally push that bone, it may push it in towards the skull. We don't want to do that. On facial injuries, make sure you have plenty of tissues, 4x4s, and try to control that bleeding. Once you find the spot of bleeding, you can start wiping it off. That's the reason why when men shave that we bleed a lot, because it's real facial around here. It's not that we can't shave. I actually cut myself the other night trying to create my line, but be cautious of that. They do bleed a lot. Nausea and vomit are signs of a head injury. That's the reason why we always tell them, hey, if you get blurred vision, you get sick to your stomach, start throwing up, shortly after this injury, you need to let us know. That's some of the things, like if somebody's very adamant on signing a refusal and they don't want to go to the medical facility with me, that's their right. But I let them know, hey, if you get blurred vision in the next couple of hours, within 24 hours, you get real sick to your stomach, you lose your balance, and you start vomiting, you must call the ambulance back, because now you have a head injury and that needs to be treated. And let them know worst case scenario, and they even understand that they could potentially die. If you understand these and you're willing to take that risk, please sign right here. I'm not trying to persuade somebody to go to the medical or to the facility, because I don't care. I mean, I do care, but I don't care their decision. They just need to understand that, oh snap, I can die if I don't, I need to know. Spinal mobilization for children's sometimes it's reserved for traumatic events, but again, what is a traumatic event? Well, your traumatic event is going to be different than mine, because you're starting new into your career. What is something that's severe to you? But remember, you're the care provider. So what you decide is what you decide. Now, greater down the road in your career, the more you get out there, the more you ride that truck, the more experience you get, the more comfortable with some things you might do versus when you started and you're like, you know what, I'm not gonna put them on a seat collar, or I'm just gonna allow them, they didn't have no complaint when I got to them, so I'm just gonna let them sit on the stretcher. And that's fine, that's okay. Some chest injuries are most likely blunt injuries. We talked about that. Strikes, helmets, baseball, a far fall. The chest wall, somewhat flexibility. No, I don't remember where I was going with that. So chest wall flexibility in children can produce a flail chest. Listen to your lungs, auscultate them very well. Although there will be no external signs of injury, the injury may be significant to the chest wall. So pay attention to that. Continue your secondary assessment on the way to the facility. And if you start to see bruising, that's signs of internal bleeding, and note that. Start assessing that area. Is there any tenderness in there? Now, again, I don't want to be pushing on it because everything in that area is going to hurt eventually because I've pushed so much. Some common abdominal injuries, that is very common. Also remember that they're stomach breathers on some of your smaller children. So when it's time for them to take deep breaths and all that, you may see that seesaw effect, and they may just breathe like that normal, but ask those babies, hey, do you normally have trouble breathing like this? And do you breathe with your stomach all the time? Some monitor the signs of symptoms of shock. You want to talk about including a weak, rapid pulse, cold, clammy skin, some decreased capillary refill, confusion and decreased systolic blood pressures. If the patient shows signs and symptoms of shock, prevent hypothermia by keeping the patient warm. We talked about that. And this figure right here was to say, and the figure on the slide illustrates the impact of blood loss on the potential for developing shock. All children with abdominal injuries should be monitored closely for signs and symptoms of shock. I don't know what it's trying to tell you folks. Sorry. All right, so let's talk about burns. I think burns, a little bit of disaster management, some signs of child abuse. It's going to wrap it up in sexual abuse and stuff like that, and then that'll wrap our stuff up tonight. So generally considered more serious than burns to adults. This is, remember, they're smaller. They don't have much to react. Their airway is a lot smaller. Infants and children have more surface area relative to the body mass, which is greater fluid and heat loss. Children are more likely to go into shock and to develop hypothermia after experiencing airway problems. The most common ways in which children are burned: exposure to hot substances, which is scalding water or held down in the bathtub, hot items on the stove because they're reaching up and they're pulling it down on them. Exposure to caustic substances such as cleaning solvents or paint thinners. Older children are more likely to be burned by flames from open fire. An infection is common following a burn injury. Sterile techniques should be used in handling the skin of children with a burn when possible. Because remember, we want to keep them clean. Remember that you got to clean that area if you can. Put wet dressings over it, stop the burn, remove the clothing. If they have any jewelry, try to get those off. Consider possibility of child abuse on any burn. Make sure you report any information about suspicious to the appropriate authorities. So on this, do I want to know what type of burn it is? Is it minor, moderate, or severe? So the difference is minor is partial thickness burn, involves less than 10% of the body surface. For moderate, it's got to be partial thickness burns, 10 to 20% of the body surface. A severe burn is any full thickness burns, a partial thickness burn involving more than 20% of the body surface, or anything involving the head, feet, face, airway, and genitalia. promise you that'll be a test question. You will see that either on this chapter quiz, your final, or on National Registry. I bet you. Pediatric patients are managed in the same manner as adults when it comes to burns. Children have immature bones with active growth centers when it still talks about their growth plates. Growth of long burns occur from the ends at specialized growth plates. Growth plates are potentially weak in certain spots. Generally, extremity injuries in children are managed the same way as those in adults. You got to splint it, cast it, and wait. Hopefully it fuses back together on its own. Pain management, those are different on children. The first step in pain management is to recognize what is causing the pain. Can I fix it, stop it, or remove it? I just need to know that. Since some pediatric patients will be nonverbal or have limited very vocal words, look for visual clues and choose the wrong Baker faces, smiley faces and all that. That'll help them. You are limited to the following pain interventions as a basic: positioning, ice packs, and extremity elevation. That's all you can do. I know that sounds like a lot of fun, and I just want y'all to know that they're gonna want way more than that. So be prepared. It's not gonna be a good conversation when you ain't got no pain medicines. Additional ALS will have those. Another important tool is providing emotional support. I add that in every report I write. Patient was kept in position of comfort and provided bedside manners. What was that? Position of comfort and comfort care was provided during transportation. Sometimes they just need to be listened to, or just that warm, calming voice. Yes, ma'am, I understand. I'm so sorry that we had to meet this way. Last time, let's go out for a cup of coffee. It's just, it keeps their mind off of that. So that comfort care take you a long ways. So let's talk about triage. When we talk about triage, the biggest one that you'll hear throughout the United States is the jump start. Jump start is intended for patients younger than 8 years old who appear to weigh less than 100 pounds. There are 4 triage categories in jump start. It is, again, green, yellow, red, and black. It's the same thing as the rest of them. Greens are your walking wounded. Yellow is they can delay treatment. They do have spontaneous breathing, but we can wait. They need to go, but they can wait. Once we get to red, these are they're apneic patients. Their responsive position of rescue breaths, the respiratory failure, breathing without a pulse, or inappropriate painful response. Those are immediate transports. I'm trying to, because I don't like the one where it says breathing without a pulse. Triage should take you less than 30 seconds per person to assess them, what they are, assign a color, and keep going. If you do any treatment to them other than the basics, you may potentially have called another person down the street to die because you haven't moved down that chain. So breathing without a pulse is going to require you to do CPR. To me, I would classify that as a black. But black is deceased or expected deceased. That is apnea without a pulse. Is apneic or unresponsive to rescue breathing. That's it. Tag them, keep on going. You can't, not just because I finished with black, but you can upgrade a patient if they are yellow initially and another care provider starts arriving and then they start assessing these patients. They can change colors. They can go up or they can go down. They're not just tagged and done. That's it. Once you get to them and you're like, oh, this patient's changing. They're changing fast, and this yellow now needs to jump in the red line and they need to go. That's fine. It's not a problem. Triage cards are made that way to where you can change the status of patients at least one time. So during that process, and it can be changed. So here's a model of disaster management on the jump start. This will start telling you your basics and how to triage them. I'm gonna let y'all read that for just a second. I'm gonna take a So you see there's very minor treatment there on those things. So trying to figure out the math thing. So that's your basic jumpstart triage table. That gives you a guidance on where to go and how to do it, and then what colors you want to start assigning. And again, you
Hey,
see
Chris,
that
I
they
got a question.
talk to me.
It is. So I noticed, so in the emergency room, we do have a pediatric situation to where the length, I see the disaster management, but in the emergency room, we had this thing called the colors. And what it is for the baby, however long is the child, is the color we father off the airway. And is this the same thing too as well too? I know a lot of them like
No,
we're talking
that is
about.
a Broslow tape. Yes, so that is a Broslow tape. You lay it out and it goes from the head to the feet, and that breaks down the dosage of medication, what size airway that they should potentially take. It is a quick, rapid chart. Too bad they don't make them in adults because it would be amazing. But to build off of that Broslow tape, some places, a lot of your big ERs, like the children's hospitals that are major, they also have a crash cart that's designated in the colors. They'll break out their syringes and they're dropped into colors too. So like if you're a pink, you get like a squirt of medicine, and that's what, from the ratio of your body to the medication, that's how much you get, and they're labeled on that vial. Some agencies I have seen already have the EPIs proportioned from a manufacturer by color also. So if you open up the green drawer, because that child is of that age, there's all the medications that child can have at that dose. So the Broslow tape and the triage is different, yes. But if you've ever had a chance to mess with a Broslow tape, they're amazing. They take a lot of the guesswork out and they pre-tell you what to do. So I have my own Broslow tape. I may have borrowed it, not giving it back, but they're very, very helpful getting out into the world, especially as a paramedic, so your drugs are already broken down. So here's the touchy topic: child abuse and neglect. Child abuse means that improper or excessive actions that injured otherwise harms the child or infant. This may include physical, sexual abuse, neglect, and emotional abuse. Over 500,000 of children are victims of child abuse every year. That's unbelievable, which I don't doubt that. Many of these children suffer life-threatening injuries, and some do perish. If you suspect child abuse, it has to be reported, and the abuse is likely to happen again if you don't, perhaps causing permanent or even more injury and death to these babies. Child abuse occurs in every socioeconomic status, so you must be aware of the patient's surrounding and document your findings. You may be called to testify in these cases, so again, document. And they may include any statements that you gave to the care provider of the scene, of what you saw, anything. Your report can be pulled and you can be questioned on your report. When it talks to says, ask yourself of these questions, you know, like the one that I say, is the bruising equal to the age of that child? What shape is that bruise in? Why does it look like a flat piece that about yay big? That's about the same size as a belt. You know, is that persistent? You know, why is it on their legs and not their butt? You know, I've been spanked by a belt for I won't say my entire life, but I got beat with them. I deserved them. So the injury is typical for the development level of the child. Is there good relationship between the caregiver and the child? And the caregiver doesn't have to be the parent. Is the MOI that's reported is consistent with the injury? And was there delay in seeking care for the child? Maybe the child is in shock, like body shock, not emotional shock. And they delayed care by a day or two. Oh, well, they fell down the stairs 2 days ago. Well, you just calling me now because they like a sack of potatoes on the bottom of the floor. You know, what's up? And is the parent or caregiver behaving appropriately? What are their actions? Are they just being overly like, no, that didn't happen. No, I need to go with them. No, we don't allow that in our ambulance. So sometimes you got to be careful because they may not allow you, but also you can call the cops and they got to take the baby to the hospital, and then the cops are involved. Does the child have multiple injuries at different stages of healing? The different colors of bruising with a different color, the different stages of scabs. And does the child have any burns on the hands or feet and involve a glove distribution? Does somebody look like they put their hand there? And does the child have several types of injuries? There's the other one. Sorry. Look for any injuries that are bruises caused by cigarettes, heating grates, or branding injuries. I don't know if I could. I've seen one child abuse case that was severe, but if I saw some cigarette burns, I don't know. I probably would go to jail because I would beat somebody. I probably would lose my job too. And I hate child abuse. I hate talking about it because it's just one of those things that we know that it's there. You don't see it, and then when you do see it, it's very shocking. Was there unexpected decreased level of consciousness? Is there any rectal or vaginal bleeding? We not saying that we are like, oh, we got to look, but if that's what we're there for, and we notice it, and it's like, And what does the home look like? Is it clean, dirty? Is it warm, cold? Is there even food there? Is there enough food for this child? Are they being starved? Are the parents healthy and the baby's not? It's kind of like, So here's a mnemonic again, child abuse. And you may remember the key points to look for. I'll let y'all look at that in a second also. All right, so bruises. Observe the color and the location. Bruises to the back, buttocks, face are suspicious, and they should indicate by a person. Who did that to you, baby? Burns to the penis, testicles, vaginal, or buttocks are usually inflicted by someone else. Burns that encircle a hand or foot that look like a glove are usually inflicted by someone else. Also, suspect child abuse if the child has a cigarette burn. That's not normal. Kids don't burn and put them out on themselves. That's just dumb adults that are drunk. Fractures. Fractures to the humerus or the femur. That's not something that happens to these babies. That is a traumatic injury that has caused that. Because remember, they're not fully grown yet. Those bones don't have a lot of calcium in them. Falls from the bed are usually not associated with fractures. It's like, oh, they fell from the bed. You know how much it takes, like how much force it takes to break a child's femur? That is not happening. And maintain an index of suspicion if the infant or young child sustains a femur fracture or a complete fracture of any bone. That's just not common. Unfortunately, shaken baby syndrome, that may be life-threatening due to head trauma. They've been hit in the head. You see that a lot more than anything else, unfortunately, here lately. We saw a lot of it when COVID first came in. You had all these lockdowns. Some parents are not used to being with their babies, crying babies all the time. It has caused some parents to do some very outrageous things. Did you potentially see any bleeding within the head and drain into the cervical neck? You look for the skull, like raccoon eyes and stuff like that. That's something you have to look for. And just pray that that's not there. Because that's pretty severe. That's a lot of force. You have neglect, refusal or failure on the part of the caregiver. Just provide basic necessities, bathing them, food, water, clothing, keeping them from the outside elements, things like that. That is just blatantly neglect. Signs and symptoms that include abuse. The abuser may be a parent, caregiver, a relative, or a friend of the family. Abused children do appear withdrawn, fearful, or hostile. They're responding to the situation, not to you. It's just they feel like it's fixing to happen again. Be concerned if the child does not want to discuss how the injuries occurred. Most of them, like, I fell off my bike and I hit my foot and I cried for like 3 days. If they're just like, nothing, nothing, because they don't want the caregiver or the parent to hear them and be like, all right, I get you. You won't say it again. So be cautious for that. It is mandatory that all EMTs in any part of their state or any state across the country report all these suspected child abuse. Supervisors are generally forbidden to interfere with the reporting of a suspected abuse. Law enforcement and child protective services will determine whether there is abuse. Even though you notify your supervisor, they cannot by law tell you not to report it. That is, they're just as guilty as the rest if they do. So if somebody's like, no, just stay out of it, you don't need to report it, that's not their business. You can bring it up to their attention so that they're aware that something that you have, and you may need to pull some, information from the call that you don't have, and the supervisor could potentially pull it up. Sexual abuse. Children of any age with any gender can be victims of sexual abuse. Maintain an index suspicion regardless of the patient's social economic situation. It don't matter who they are, how they are, they can be abused. Unfortunately, that's what happens. You should limit assessment should be limited to determining the type of dressings and injury requires. Treat any bruises for fractures as well. Do not examine the genitalia of a young child unless there is evidence of bleeding and there is any type of injury that must be treated. So don't be like, oh, well, gotta look. No, that's not your business. That's not your place. That's not in our scope of practice. And again, that's potentially child abuse on you, sexual assault. Do not allow, if you suspect any sexual assault, do not allow the child to wash, urinate, defecate before a physician completes the exam. Ensure that EMT or police officer of the same gender remains with the child, and maintain as much composure as you can during this process. Obtain as much information. The baby will talk to you, get as much as you can, fill out as much paperwork, make as many notes, times, dates, locations, and just write notes and hand it over. Sexual abuse is a felony. That is something they will go to jail for. But again, it's got to be something that's advised. It needs to be reported. If you don't report it, there's nobody, we're not going to know that. So we have to be careful and make sure that it's legit and report correctly. So patient assessment and management. It's the same when we're dealing with any part of this career that we've talked to in this curriculum is listen, pay attention to their issues. When we talk more into the infants and patient assessments, we have to deal with infants as SIDS. That's something that we just, sometime in your career, you probably will run across that. Even though you suspect SIDS, you need to follow what your local protocols say. So SIDS patients will be blue, not breathing, they're going to be pale, they're going to be unresponsive. They've passed and has been passed maybe something else that we don't know, but the parents want you to do everything. Well, that's what they called you for. Well, I'm not whom you believe in, and I don't want that to take place. So be cautious. It may be something that you don't want to interfere in a crime scene, because you go to moving the child or doing this or that, that's interrupting a crime scene. So some of the things that may cause SIDS, as y'all see right there, as y'all have looked at, there's some other potential signs, and their assessments. It's the same thing. It's going to be your ABCs, provide intervention as necessary. It's hard not to work a pediatric injury, a death, SIDS. You're not going to be able to fix and solve everything. It's just not gonna happen. So being able to be there for those answers and questions, because they expect you to do stuff, it's just not gonna work. So be cautious of your surroundings during that time too. Depending how much time has passed, the child may show signs of postpartum, and they will include stiffness. You may have pooling of the blood on the bottom side of the child, or it could be that they're laying face down. If you have any of those signs of postmortem, you need to call med control, notify the police, notify the coroner. It depends on what your protocol say again. If you don't see any signs of rigor mortis or pooling, you got to start CPR, period. If you say that you suspect SIDS and the child's unresponsive, but they're limp and warm, you need to work that baby. You need to do everything in your powers, perform as best and the best CPR you've ever had. I recommend removing the child at that point and put him in the back of your ambulance and just go. If you know deep down in your gut tells you that that baby's not gonna make it, you still gotta try. That's our job. There's times that you will just run across these calls and you just be like, it's just not, because you know what's gonna happen. Pay special attention to any marks or bruises on a child before performing any procedures. Note any intervention that was done prior to your arrival. What did they do? Did the parents do CPR? Did they change the baby, change the sheets, and things like that? What happened? I don't see any. They have a clean diaper. That's not something that should be done in a traumatic situation. Note those. So on your scene, assess the scene. Should consider the following: signs of illness, including medication, humidifiers, or thermometers. You're taking a very visual picture of the room. General condition of the house there, signs of poor hygiene. Is the baby even manicured right? I mean, is they hairbrush, things like that. What is the family's interaction due to this traumatic situation? Where was the patient found? Was the baby in the crib? Was it in the bed? Or was it dressed and already in the car seat when you got there? And you're like, this just don't look right. Communication and support of the family after the death of the child. You tend to get into some very emotional responses. You can potentially have anger, a lots of crying. Allow the family to express their grief if the baby has been pronounced or it's dead prior to arrival. But no, there may be some anger out there, so keep your distance and let them know. Be like, hey, listen, I know the officers are here, but we're going to step back into our ambulance. If you need anything, we're not going anywhere, but please let us know. But keep your distance and, protect yourself. Provide the family with your empathy, high level of care, your bedside manner. You need to introduce yourself. You got to just play that fine line. It's, some people, when some people want to be spoken to, and then when some people don't want to be spoken to. So be cautious on that. Make sure that you can read those people, because sometimes they may not want you to even mess with them. And they need their time of grieving. It's rough. Don't assume what's going on. The family should be asked whether they want to hold the child or say goodbye. See, that's out of my realm. I'm not diving off into that, because that's something that we just. I don't know if you want to do that, because I don't transport deceased patients in my ambulance. That's just what happens once they've been pronounced deceased. Ambulance don't transport, and the coroner comes out. That's a coroner be a problem, not mine. Try to use the child's name when you speak to the parents or caregiver. I like to say they've passed. I don't like to say they dead or died. Just sounds better. You do you grown. So understand that when you make those calls or decisions or something like that, that you can make that call. It's not clicking all of a sudden. Leah, how'd everything go? You got your eyes like that. You say you did your ride alongside. Everything went good? she's typing, I'm sure. What is the problem? Death of a child is rough. Death of a family member is rough. I know we're all grown folks. At some point in time, we've all had to deal with death in our own way. And imagine if you haven't already had to deal with it, being a care provider and experiencing death, and everybody's looking at you, and you're like, I didn't do nothing, but emotionally they're upset, and you don't know how to fix that, and that's okay. So be careful. Sometimes you may need to meet with some people, and talk to somebody. That's part of the job. I mean, you may not know how to deal with it. The first child that I worked as a juvenile, I mean, as a young paramedic, I knew his parents, and I know his parents very well still. He didn't make it. He passed. He was the same age as my oldest son. I was the first one to get there, and he looked at me and he was like, "Wow, it saved my baby." And I know him. I still talk to him. It's rough. It's hard. I cried for days. Like, I was tremendously upset, but that's okay. That's how we deal with it. I've learned, as getting older, it's okay to cry. You don't have to be a tough man all the time, because I don't really care anymore. If I gotta cry, I'm gonna let it go. Again, here, talk to colleagues. If you need some time off, let your department know, let your family know that what's happening. Don't just withdraw, because it's rough. I hope that you have a good partner, fire truck, ambulance, something like that, that you build a work relationship and a personal relationship with, that you can hang out after work and you can say, "Hey, look, I'm up from that call the other night. I'm having trouble." And they realize that, and they can talk you through it, or work you through it, or you can work them through it. No matter what, that's your work relationship. Be courteous and open ear, and deal with life. It sucks. That is probably the worst times that we have to do in our career, is death. But again, people don't call us to the birthday parties. We get to see the worst of the worst majority of the time. And a lot of agencies don't provide that emotional support. And that's bad. And I think that they should provide those things a lot more often. Guys, that's the end of the class. I don't have anything else to add. Again, it's our second night, so here's your code. We do have one more class left, and that is geriatrics. That will be Thursday night, and then we're done. I will discuss some of your final, what to do on your finals and all that Thursday. Finish your boot camps, finish your ride-alongs. Praying everybody passes their finals. We will, once everything's done, I'll sign off on all your paperwork along with Rob, and you will be submitted for National Registry. Be available to take it. I encourage all of y'all to please let us know when you take and pass and what you did. And I ask that you can share some of your information, like your test results, so we can see, and then we can help you out if you would like. We are also working on potential everything from the start to the end. I did your final the other day, and it's included everything from chapter 1 till the end of it. It's lengthy, I'll tell you that. It's lengthy. You should have enough allotted time.
I just pray to God that at the registry, when I take my test, it'd be nothing but trauma. I'm an AC.
Rob and I have talked. We are going to offer some training classes. I don't know what the expense of that's going to be, like, not training, but tutoring classes to prep you for. I don't even know about expenses or anything like that. I will. That's Rob. Maybe he'll let y'all know, or he'll pass it out to the group. I know that myself, Rob, two of our other instructors, and some other associates will be. So it depends on, like, if we do a trauma night, you may have Joe from wherever, and he's going to be teaching the class. I don't know how that works. Rob will get that information out to you guys soon. Guys, here's the code for the class. Please note that down. Check it out. Kobe, give me a second. I will read your question. Give me a second, Kobe. I'll answer that. So there's your class code for the night. This is for both classes. Please, please, please make sure you watch the first night if you have not already, because when you go to take your test, you're going to see variations of both nights. It was just too big for us to do into one night of class. That's why we decided to break it up. But Thursday night is your last night. And then once you have gotten to do your last boot camp, your final will be ready. So other than that, guys, y'all are more than welcome to bow out. Kobe, give me a second. I will respond to you. And shoot me just a message on Discord, Kobe. We'll handle it that way.
Chris, I had a quick question.
Please.
So I don't know, I haven't checked it yet, but I was just gonna ask you real quick. Have you and Rob kind of discussed when you guys are planning on starting the advanced class?
I don't know. Rob's been on the road a lot here lately. I know that we should start, like I start my next EMT class January 4th. So I would say the next advanced class should be right around in that too. We should start there right around the same time. At least by the second full week of January, we should start an advanced class.
Okay, sounds good. I appreciate it, Chris.
No problem. Thank y'all. Good luck to y'all, and have a safe night. And I'm gonna mute my mic, leave it here for a second. But Kobe, just hit me a message, and I'll get that situated from you.
Yes, sir. I'm doing that right now. Appreciate it.
All right, y'all have a good one.
Thanks, Chris. You too.